Hi, everyone. Thanks for listening. My name is Rahul Banerjee. I'm an assistant professor of medicine at the Fred Hutchinson Cancer Center in Seattle, Washington. Every year is busy for myeloma at ASH. This year was busier. There was one session where there were like three back-to-back myeloma sessions happening at the same time. I would say if I had to choose one study that probably will be the most practice changing very soon, it would be the AQUILA study. So the AQUILA study was a study of daratumumab in high-risk smoldering myeloma versus active observation. And in brief, and we can talk about this at length, and Dr. Vincent Rajkumar was the last author, Dr. Thanos Dimopoulos was the first and presenting author. It showed that there was not only a PFS benefit with a progression event defined as real myeloma, not just an M spike rising. There was a PFS2 benefit, and there was also an overall survival benefit as well. And one of the slides he showed, it wasn't powered to look at PROs, patient-reported outcomes, but at least at week 12, the DARA arm seemed to be actually feeling better and doing better as well. This is great. It's not FDA approved yet, and I'm not yet starting a patient with high-risk smoldering myeloma on daratumumab. But our patients who have high-risk smoldering right now, they're kind of stuck. Some don't want treatment, and if they don't want treatment, great. There's always a discussion to be had. Some are nervous, right? They have baseline chronic kidney disease, or they have family history of myeloma or osteoporosis, something along those lines. And the standard right now for them has either been active observation, a clinical trial, which I've put some of these patients on, or standard care lenalidomide, which is messy. Has a lot of side effects. Dara, I would argue, is much better tolerated than lenalidomide monotherapy for these patients, and so I'm excited about it. So I would say that would probably be the biggest one that all of us were, very, very carefully looking at. I think there were a lot of other nice ones as well. Those of you who know me know that I love looking at the patient experience and lowering toxicities, and so there was kind of two nice abstracts. One by Dr. Gordon Cook and colleagues in the UK with a frailty adapted induction strategy. So in brief, they randomized patients getting a triplet, not a quadruplet, but a triplet, and kind of older, frailer patients to either get normal ixazomib Revdex, so a normal triplet with a reactive dose adjustment. So if they had a toxicity, then you lower to lenalidomide or the dexamethasone, et cetera. Or a proactive strategy where based on the patient's age, fitness, et cetera, you proactively chose a lower starting dose for them. There actually was a mortality benefit to the latter approach. Interestingly, it was driven not so much by the frail patients, but by the non-frail patients who were a little bit less fit, but not frail per se. And the reason this matters is, unfortunately, a lot of these trials that use the maximum tolerated doses of all these regimens. A good example is MAIA. And MAIA is an excellent regimen, DARA-RD, for transplant-ineligible patients. But that study used len 25 milligrams. That's a very high dose of lenalidomide for someone older and frailer. Dex, I think, was 20 milligrams in that study. But here they show that if you kind of proactively go lower, you might actually have a survival benefit. The other DEX-related research that people might not find surprising, but I think is absolutely practice-changing today, was the IFM 2017-03 study presented by Salomon Monnier and colleagues, and that was the hashtag Down with Dex study. What that was the study of was basically for someone older, less fit, getting lenalidomide, what's the best partner drug for them? Is it Dex? Is it RD? Or is it DARA? Is it DARA-R? So the study of DARA-R versus RD. DARA can cause infusion reactions, and people sometimes newly diagnosed have a lot of symptoms, need some dexamethasone, but it was only 8 weeks. Only 8 weeks of dexamethasone. Unlike DARA-RD, which is Dex forever, sometimes 5 years for these patients on average for their median PFS, DARA-R and Dex only for 8 weeks. In the rare event of any infusion reactions, they could get prednisone later. And basically, overwhelmingly, DARA-R blew RD out of the water by every metric: PFS, OS, patient-reported outcomes. Again, if you were to ask any myeloma specialist, is this surprising? Of course not. We all know that DARA is a better drug than Dex, but I would argue that this study is a randomized study, and that active arm, DARA-RD, where Dex stopped after 8 weeks, that is the new standard of care. And so for those of you listening to this, if you are still keeping your patients on Dex, especially the older, frailer ones, but I would argue any patient newly diagnosed, if you're keeping them on Dex past 8 weeks, think about it. Because I would argue that now more and more data, my work from the SWOG secondary analysis last year, there was a big study from LaRocca and colleagues in Blood a couple of years ago. More and more we're seeing that Dex is dispensable. All dexamethasone does is cause people problems like cataracts, muscle weakness, insomnia, hyperglycemia, go on and on and on. So I would say Dex is fine from the beginning. I'm not saying abolish Dex. I'm just saying down with Dex. After 8 weeks, after 2 cycles, plan to drop it or at least lower the dose, if not drop it entirely. Dr. Rakesh Popat from the UK presented nice data on the correlatives from CARTITUDE-4 looking at MRD rates. And unsurprisingly, we already knew that in that particular study, ciltacabtagene versus standard of care regimens, ciltacabtagene had a PFS benefit and now an overall survival benefit. And I should add dramatic, again, PRO benefits, patient-reported outcomes off the charts. Even by the 3-month mark, the CAR-T arm is feeling way better than the arm that's getting standard therapies. Here we saw that MRD rates unsurprisingly deepened with time, which is really nice to see. I think the biggest interesting drug that was presented at ASH was anito-cel. So that was formerly known as CAR-T ddBCMA. Chiara Freeman, Dr. Freeman and colleagues presented that data from the phase 2 study and basically found that patients with anito-cel did well. And anito-cel, hard to say, it's very hard to compare between trials. We all say don't do it, and then we do it anyways. But basically, I think ciltacabtagene has some very impressive efficacy in patients with relapsed refractory multiple myeloma. And anito-cel seems to be tracking somewhat similarly to that, as far as we can tell. The $1,000,000 question, literally speaking, is anito-cel, does it have a lower risk of delayed neurotoxicities like Parkinsonism, Guillain-Barré syndrome, etc.? At least in those 98 patients who were treated so far, 90-something patients on anito-cel from the 2 studies, there have been no cases of them. Again, very hard to compare between studies. Ciltacabtagene has been around for much longer, so time will tell, obviously. But our patients always want more options, and Parkinsonism can be scary for patients, even if it's a theoretical risk, even if it's small, less than 1% risk in the modern era. But so it'll be interesting to see how that study plays out in future, phase 3 studies and so forth. Great question. So, you're asking now, for example, like studies like CARTITUDE-6 that is ongoing now, and that is a study of dara-VRd to CAR-T, ciltacabtagene, and len maintenance versus dara-VRd to transplant and len maintenance. That study will be very interesting. It's already accruing in Europe and now some American sites as well. And it'll be very fast. It's going to take 5-6 years for that study to read out. It will be really interesting. It's not going to quite represent how we're using CAR-T right now because, again, they intentionally are giving both arms lenalidomide maintenance. In real life, as of now, I'm not giving my patients len maintenance after CAR-T therapy. But it'll be really interesting. I actually don't know which way it's going to go. I'm hopeful that CAR-T will have the upper hand here because obviously we're very bullish about it, and I think it's often more tolerated than the transplant for many patients. However, we'll see. Transplant is a formidable foe. It's been around for 40 years. It's going to be hard to uproot, so we'll see. There was a study presented by Dr. Nadim and colleagues of CAR-T in high-risk smoldering myeloma. So same drug, ciltacabtagene, in high-risk smoldering. So Dr. Nadim was the first author. Dr. Irene Gabriel at Dana-Farber was a senior author. And it worked really well. 100% of patients achieved MRD negativity. What we don't know is, with further follow-up, what toxicity do they have long-term? Because again, ciltacabtagene does have that issue of long-term toxicities low, but very low risk, but possible of delayed neurotoxicities, Parkinson's, Guillain-Barré, etc. I already talked about AQUILA just now in the high-risk smoldering myeloma arena. How would CAR-T factor into that? Who's going to win, CAR-T versus, daratumumab? It's not a competition because they're very different patient populations. Like what I always remind people is that smoldering myeloma is, we say that myeloma is 100 diseases all into one. Smoldering myeloma is 1,000 phenotypes put into one, not just disease phenotypes, but patient phenotypes, right? I talk to my patients about it. Some patients, they don't find me I don't find them for the trial. They find me. They are very concerned about this. They are very interested in a durable solution to just eliminate it, to completely eradicate this, intercept it, never have it come back. For those kinds of patients, CAR-T or teclistamab may be appropriate. For other patients, they may want the less intensive strategy. Daratumumab may be the option for them in the future. Others may want to just observe and see what happens because our predictive models are not perfect. Very reasonable. You have to talk to the patient about it. What I would say to your question about, CAR-T in smoldering myeloma, again, I think we'd have to limit it, practically speaking, to the patients who need it. I think we need better prognostic models to identify who is at highest risk of progression to morbid symptoms from active myeloma. And I think we need a way to just make the product safer and more logistically capable, right? Because half the world, for example, doesn't even have access to daratumumab of any line of therapy, let alone in smoldering myeloma. And here we are in the U.S. talking about CAR-T for smoldering myeloma, right? I acknowledge that it's hard, that we have this luxury of options, but many countries in the world do not have that. So I think I would say that CAR-T for smoldering, we need a way to operationalize it, and we need a way to make it more practical for patients who need it, no matter what state of the U.S. they live in, or perhaps wherever they live internationally, if they decide that CAR-T is the right one for them. I don't think anyone with smoldering myeloma should be forced to choose any one one way of action because there is no one right answer. It's a very hard decision based on disease biology, patient preferences, evolving trends over time and whatever treatment you're considering. But I think it's good to have more options and not less. I'll tweak that question in terms of what will be the most practice changing very soon based on data presented here. You'll laugh, but actually, I think it won't be a new drug. It will be new response criteria. So the International Myeloma Working Group response criteria were last updated like a decade ago, basically, and they've worked pretty well, but they have some problems, basically, in terms of how you define complete response, how do you define progressive disease. So two abstracts I'll talk about briefly. One, full disclosure, was my own, was the data that I presented about a secondary analysis from BMT-CTN 0702, the STAMINA study, showing that 24-hour urines are basically dispensable. They're not required to response assessments, and that urine-free response criteria work just fine. So just as an example, what I mean by that, some on my patients on clinical trials, we are asking them to do 24-hour urines every single month. We never ask our patients in real life to do that, with the exception of AL amyloidosis. But on trials, they have to follow the book. And the book is the old IMWG response criteria that look at 24-hour urines as a marker of complete response or progression, etc. And it's hard. 24-hour urines are just a lot for patients. They're very cumbersome. Patients are older or frailer, have a harder time collecting these urine jugs, keeping in the fridge, etc. Patients who are unhoused or work weird hours, hard to have access to a fridge. Collecting a urine is harder for women than it is for men. Carbon footprint, financial cost of trials, so many issues with 24-hour urines outside of AL amyloidosis where they're validated for response assessments. And basically found that urine-free criteria work great. Another oral abstract by Jean-Sébastien Clavier and colleagues looked at, is there a better way to look at progressive disease? Right now, to quantify progressive disease, you have to have two separate assessments back-to-back confirming disease progression. You might think, oh, that's just like an academic debate. It's a real issue. So the example I'll give is a Canova study of venetoclax in myeloma. All of us were hoping for it to succeed because venetoclax does work for T11, 14, multiple myeloma and amyloidosis. I use it all the time for my patients. The study failed. It was a negative study, mainly because even though there was a trend toward overall survival benefit and time the next treatment was better with venetoclax, a lot of patients in the control arm were being censored. As soon as the light chains were rising, their doctors were taking them off the study, even though they didn't have confirmed PD. And so basically that requirement for confirmatory disease basically led to an important drug not being available to our patients. Very, very real world significance of that particular concept in the current response criteria. And so IMWG is working on revising that. And so in the next year, we hope to see revised response criteria that are smoother and more streamlined for patients on clinical trials. But again, these trials have real world consequences, as I alluded to. So I think that will be the biggest thing. That will be probably the biggest paper, because as soon as it comes out, the trials start updating things. And I'm hoping that it'll be allowing more patients to get on trials, more patients to be evaluable on trials, right? Because the worst thing is that you convince your patient to do a trial, they put their blood, soul, sweat, and tears into being on this clinical trial, and then they're all of a sudden non-evaluable because of some missing urine or some random thing. Getting more of these results to count on clinical trials will be very helpful. So I would say that is going to be, I think, the most big development of multiple myeloma, is just a more streamlined way to say how is someone actually doing when they're on treatment.